project, I did the operation room scheduling and optimization of our operation theaters at the Warcare Hospital. Back then we had 3 general surgery operation theaters, and I decided to optimize our traffic through them. And while doing that, we wanted to achieve the best optimal capacity that was possible in those 3 theaters. So the Warcare Hospital is a leading partner with State Life Insurance Corporation for the healthcare service delivery in the universal healthcare coverage under the similar program. We wanted to increase our surgical turnover because the only way you can remain profitable or even break even in this very tight insurance program is by having a maximum surgical turnover. So our goal was to optimize our overall scheduling and reach the optimal capacity that we could through our operations. But while we wanted to increase our quantity and reach that maximum level that was possible in those 3 wards, we wanted to make sure that we do not compromise on quality and therefore have the necessary key performance indicators to make sure that we are delivering on the quality we promised. Our main challenge was our hospital infrastructure. Like you can see, so the Hawking Hospital is vertically built hospital. One of the challenges that we face is that we have a single bed elevator and our operation theaters are located on the 3rd floor, while our private rooms on 2nd, our wards on 1st, and our emergency room on the ground floor. So single bed elevator has to manage all the traffic efficiently on the day of surgery between shifting the patients to the operation theaters and from the operation theaters, making sure that we do not waste time, making sure that the communication is good enough. So for methodology, I decided to go about as an interventional study. For the first thing, what I did was I mapped the entire process of the patient journey on the day of surgery, mapping all the necessary steps, processes, taking time, accounting for all the times. And by doing so, I was able to identify the bottlenecks, which were the patient shifting both to the OR and from the OR, and the surgeon arrival as well as the OT medicine delivery. Based on our findings, I was able to calculate the optimal capacity that we could achieve in those operation theaters. If we were to run for 12 hours per day, we could easily manage 8 operations per day per OT without compromising on any of our sterilization protocols. Then we came to the interventions. We implemented certain interventions. We increased the human resource allocation, making sure that the OT staff, which is involved in the surgeries and is getting washed up, is not tasked with the communication of shifting the patients to and from the ward. They should be the person who is managing and running the patient traffic should not be washed up, otherwise they will not be able to focus on both jobs at hand. Then we did provide them with certain tools, communication tools like walkie-talkies that allowed them to communicate with the elevator staff, the operation staff, and the floor staff. This allowed for the smoother communication. And then we continued to calculate our data and times as we were doing initially to compare what was the result and what did our interventions help us with. Documenting the improvement was very important. Then to make sure that we do not compromise on our quality, we decided to have key performance indicators which were looking at all the facets of the operation theater working. We had volume indicators like case volume and the case minutes, utilization indicators indicating what was the utilization per day of the month so that we could be prepared for the necessary staffing, operational indicators in which we managed cancellation rates, add-on surgeries, especially surgical site inspection, to make sure that we are being aware of any sterilization protocol breakdowns that might be there. It is very important to chart this up so that we are not compromising on quality. Then the functional indicators were just as important from a accounting point of view because we had to manage the medical supply cost, what were they compared to the surgical procedures that we were undertaking, and contribution margin per OR hour, helping us decide which specialties and which particular operations within each specialty we needed to invest more. Because we were working with the solar program and we had to make sure that we are not investing on things that are not profitable to us and otherwise costing us to invest or not breaking even. So we had to make sure that our resources are allocated in a way which is also useful to us. So these are some of the graphs that we were able to draw before and after intervention. The The OT shifting time after our intervention reduced from 10 minutes to 9 minutes, 10 minutes to 7 minutes in case of OT shift from the ward to the OR before the surgery. Post-surgical shifting time reduced from 9 minutes to just under 7 minutes. And initially, the throughput time, the surgical times were initially a bit, in the beginning of the months, we saw that they were going a bit high, but we were able to average it out over the months through our data. Then these are the graphs we obtained after we charted up the key performance indicators. Our monthly surgical volumes were able to tell us which were our high surgery months and which were comparatively low, like in December. We get a lot of holidays, so there is a low number of surgeries go a bit down. Also, because we were catering to a lot of people on the Sinner card, when the co-payment was introduced, we saw a sharp increase in the numbers of the surgeries, and then they started steadily rising. Then the average case per minute for certain surgical procedures. Then percentage utilization by the day of the week, which helps us decide about the staffing. OT cancellation rates were very important because they OT cancellations cause a very precious loss of the time that are scheduled. We managed to look into those things and we were able to remove some of the difficulties. One of them was coming from the these operation theaters where children could not be kept NPO for a very long time. If their surgery was delayed, we were faced with the cancellations because children, parents would get agitated and we just feed them, or for some reason they wouldn't want to move to the surgery. So what was our impact? We could improve the patient shifting times of the OR by 30%, patient shifting time from the OR by 23%. Our surgeon satisfaction improved, leading to better retention. We are a private care hospital. Our customer is not just the patient, but also the surgeon. So we have to make sure that we give them a service that helps them to choose us over other hospitals. Our progress starting helps us to improve patient safety, patient satisfaction of service, improve our surgical outcomes were very good when we looked at the surgical site infections, and there was much decreased rate of cancellation once we could get to the heart of it. The lessons that we learned in those 3 awards help us scale ourselves. Currently we are running about 8 operation theaters and we are charting the same progresses regarding key performance indicators, and we're applying the similar lessons there. So this was my project.